Good evening, and welcome to AUA's Managing Male OAB update for the APP 2025 live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.50 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of a CME activity are required to disclose to the AUA, as the ACCME accredited provider, all financial relationships with any ineligible company, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during the presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you access through this activity into external applications, bots, softwares, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank Sumitomo Pharma America, Inc. for providing an educational grant in support of this activity. Finally, I would like to introduce and extend a special thank you to our course director, Dr. Karina Hughes. Karina Hughes is a nurse practitioner in the Department of Urology at Mayo Clinic in Rochester, Minnesota. She's a board-certified family nurse practitioner who holds a Doctor of Nursing practice degree from the University of Kentucky and completed the Mayo Clinic Advanced Practice Provider Urology Fellowship in 2021. Dr. Hughes's clinical expertise spans urogynecology, men's health, and cancer screening and surveillance. She maintains a special interest in outpatient procedures, particularly MRI and TP fusion prostate biopsies and cystoscopies. A strong advocate for advanced practice provider education, she actively speaks on various urology topics, both locally and nationally, and is a member of the American Urological Association APP Education Committee. You can follow her insights into the life of a urology MP on her social media at Uro Nurse Practitioner. I will now turn the course over to Dr. Hughes.
Thank you. Based on the documented educational need, the AUA recommends a targeted live webinar to update APPs on the latest advancements in the management of patients with OAB, specifically OAB associated with benign prostatic hyperplasia. After participating in this CME activity, participants will be able to complete the learning objectives noted on this slide. So tonight, we will explore the overlap between overactive bladder and benign prostatic hyperplasia, two highly prevalent yet often undertreated male conditions. This conversation is often underappreciated, so please feel free to engage and ask questions. We have an outstanding panel tonight, a urologist and an advanced practice provider, both deeply experienced with managing lower urinary tract symptoms and overactive bladder. Dr. Victor Nitti. Dr. Nitti is a professor of urology and obstetrics and gynecology at the David Geffen School of Medicine at UCLA. He is also the fellowship director for that ACGME accredited program. He is a graduate of Rutgers University, New Jersey Medical School, and did his urology residency at SUNY Downstate in Brooklyn, New York. He then completed a fellowship in female urology, neurology, and reconstructive urology at UCLA. Adam Mogul. Adam has been a physician assistant since 2003 and has specialized in the field of urology since 2006. He practices general urology with a focus on male sexual health. Thank you, panelists, for being here today. To start, let's ground our conversation in the epidemiology of OAB among men with BPH. Studies show 30 to 40% of men with BPH also report OAB symptoms. The 2024 AUA SUFU Guideline now includes specific guidance for these men, marking a shift towards appropriate OAB treatment. Let's start by defining male OAB and its causes. Adam, how do you define overactive bladder in men, particularly when it overlaps with bladder outlet obstruction?
Thanks, Dr. Hughes, and thanks AUA for having me tonight. I define OAB in men with BPH as symptoms of urgency, frequency, sometimes nocturia, and often paired with incontinence episodes in the presence of obstructive symptoms. So those would be weak stream, urinary hesitancy, or sensation of incomplete bladder emptying.
Absolutely. Dr. Nitti, this is a question that definitely highlights the why for our actions. What pathophysiologic changes explain why some men have OAB symptoms?
Well, thank you, Dr. Hughes and Adam. It's a pleasure to be here with both of you. This is a really interesting question because I think you could take this from two aspects. The first aspect is, well, OAB symptoms in men could be caused by the same pathophysiologic changes as OAB symptoms in women, whether that's an aging bladder, whether that's subtle neurological changes. That can certainly be the case. We also know that there's an association of bladder overactivity with bladder outlet obstruction, typically seen in patients with BPH. We know that or at least we believe that there is some causative effect of the obstruction and the detrusor overactivity or the overactive bladder symptoms. But it's very difficult, if not impossible, to know in an individual patient if their overactive bladder is directly related to their benign prostatic obstruction or if it's independent of their benign prostatic obstruction. So I always look at it like, yes, the two may be related, the two may be independent, and as I decide how I'm going to treat a patient, I'll consider those factors.
That is a great point. Sometimes it can be difficult to explain to those with BPH and OAB symptoms of, hey, this is exactly what's going on and the why. I tend to draw the urinary system, draw the urethra, the prostate, and the bladder with it, and I talk about remodeling. What insight do you provide for your patients when you're trying to explain that in terms that your patient can understand the possible why?
I will, I try and relate it as much as I can to the patient's specific symptoms. And I think why is a little bit easier to understand when you put it in the context of what's happening to the patient every day. And if the patient, if the patient describes this incredible sudden urge, my gosh, I got to get right to the bathroom or I'm going to have an accident. I'm going to wet myself. Put it in that context and say, okay, here's what's happening. The bladder's contracting without your permission. What are some of the things you can do to fight this off? What are some of the things we can do to treat that, whether it be related to treating your BPH symptoms if you have them, or independent thereof?
Adam, so how prevalent is having an overactive bladder among your BPH, your male BPH patients?
Great question. And I think it holds back to what Dr. Nitty was talking about. There's such a crossover in our patients, and we've seen it for the years we've been practicing, and now it's finally getting some recognition in the literature. I see probably the majority of my BPH patients have similar symptoms to OAB. We're looking at urinary frequency, urgency that brings them in. Nocturia is a major complaint, which can have a lot of different reasons for it. But I think overall that overlap is very heavy, and you have to really determine which side you're going to treat first. Or sometimes they come in already being treated for BPH, and you're like, well, they're still symptomatic. Now we go to the OAB algorithm and start treating them there.
I'm curious to hear your both perspective as an APP. I've always been impressed that patients with the most bothersome symptoms in patients with BPH are the overactive bladder symptoms, particularly if they have urgency incontinence. And that usually trumps a slow stream or difficulty emptying. And most patients, when you ask them, they can deal with the obstructive symptoms, except those that are really struggling or in retention, but they have the much tougher time dealing with those overactive bladder symptoms.
I agree. That's what brings men in when they're leaking, because that's changing their lifestyle. They're buying pads, they're running to the bathroom, they've got keyhole urgency, and those things really affect quality of life, sometimes more than just a slow stream. So I think that is driving them to your door sometimes a little faster than BPH.
If there are mixed symptoms present, which that's what we commonly find, my first question I ask whenever I walk in the room is, hello, so and so, what is your goal today? And that definitely leads how my education is and what we prioritize. Because if today I focused all on BPH, because yeah, they have some obstructive, but yeah, if they're having lots of urgency and that's what I dismissed, not leading them towards their goal. But if their goal is improving their urgency and frequency, that ties into the education, I will bring in that BPH component so they're aware of the whys behind that. And I really try to make the first visit very foundational and provide a lot of education so they can feel empowered in their next decisions.
I think that's an absolutely critical approach. Where do we need to go? And, I have oftentimes when I see patients, they've been seen by my resident or my fellow, and I kind of know their history when I go into the room. And the thing that I'll start out with a question is, what do we need to make better?
Mm-hmm.
And it's very similar to what are your goals? And I think that's really important to know as we start to direct therapy.
Mm-hmm. I find that knowing the goal in mind can empower the patient, and they can just take a lot of that with them and into knowing what they need out of the visit. So we had talked about there's some guidance now in regard to OAB in men. Dr. Nitty, what is the current AUA guideline guidance towards OAB in men?
Well, the first thing I will say is that the guideline for OAB in men is the same as the guideline for OAB in women. We can add BPH to it, but the guideline doesn't really change that much other than to say it is okay to treat OAB and obstructive symptoms together. It's okay with proper evaluation and shared decision making to treat OAB symptoms independently of, we call them BPH symptoms, but I like to say obstructive symptoms. So it's really the same guideline, but the new guideline is different because it specifically addresses BPH and says that, with proper evaluation and shared decision making, you can treat OAB in a BPH patient the same as you would in a patient who doesn't have BPH or in a woman, for example. And I think that's really important. But again, proper evaluation, understanding the patient's needs and desires, and shared decision making.
Absolutely. I do appreciate this guidance being there because I feel like the initiation of an OAB med, whether that be an antimuscarinic or a beta-3 agonist, has been somewhat taboo in some
Mhm.
cultures of initiating those in males with fear of some side effects, which we'll talk about a little bit later on. So I appreciate that being present in the OAB guidelines and just emphasizing that and making it more okay for us. Adam, how did these updates influence your approach in to share decision making with your patients?
Well, again, these guidelines, they've given us more clarity in our role in treating patients, and they give us a little more freedom, I guess, on paper. I mean, we've always done it in urology. We've always treated both, but now it gives us a little more clarity on how to do it and when to do it. And I like that it's not a stepwise therapy anymore for OAB with men with BPH. You can start anywhere along the chain, dependent upon what the patient needs. So if they're not good candidates for medication or they failed medication previously, you can start with a therapy like neuromodulation or chemodenervation. So there's a lot of options for you as long as you've worked up the patient correctly, so that you're avoiding any dangers of retention or anything else that happens with these OAB patients.
That's correct. So since we're talking about the evaluation, let's dive into that. So we got an excellent foundation. Now that we understand the scope and burden, let's explore how each of you approaches the clinical evaluation and what pearls help guide next steps. One of the biggest challenges we face is distinguishing voiding symptoms from storage symptoms in men. Dr. Nitty, how do you handle patients with mixed symptoms? Do you target obstruction or storage first? I think we
So usually all things equal, I will often target the most bothersome symptoms first. Now, the exception could be in a patient, generally when patients come to me, they're having an evaluation that consists of a uroflow and a post-void residual. So if a patient has mixed symptoms and they have a poor flow and an elevated post-void residual, I might focus on those obstructive or BPH symptoms first. But if emptying is fairly normal,
Mhm.
I will usually focus on the most bothersome symptom first. Now, there was a question in the chat regarding, is it okay to treat overactive bladder symptoms in a patient with BPH medically without treating the BPH symptoms first? And I would say, yes, that's a very reasonable thing to do. And the patient who has predominantly overactive bladder symptoms has pretty good, and I'll let you define pretty good however you want, emptying, it's fine to start with an overactive bladder medication. If that's not enough, then do you switch your overactive bladder medication? Do you add a BPH medication? Those are, again, that's a shared decision-making thing, but I think it's totally reasonable to treat overactive bladder symptoms first in the patient with mixed symptoms when those overactive bladder symptoms are the predominant symptoms.
I'm glad you noted the point of getting a post-void residual. That leads to the question of, Adam, what is your workflow for a baseline evaluation for lower urinary tract symptoms in those with a prostate?
So I generally start with an IPSS score. I like to have a baseline objective score to go with. Men are terrible at thinking back about how they were when they were worse. So you give therapy, and then 6 months later, I don't know if I'm any better. But if you've got those scores, you can say, you went down 4 points or 6 points on the subjective scale, and it actually means something. I also, of course, do a UA, typically a prostate exam. Uroflow is key when you're trying to understand obstruction, obstructive uropathy. And a bladder scan or ultrasound is also imperative if I'm going to treat OAB with suggestive obstructive symptoms. I want to make sure that they're not, in any degree of retention or incomplete bladder emptying. Someone mentioned in the questions, what's the cutoff? I mean, I think we all have our own comfortable cutoffs. For me, it's 150-ish. If they're stable at that for a few visits, then I'm good with it. If they're 300, I'm not giving them an antimuscarinic, and may even not even give a beta 3 agonist until we've dealt with the obstructive uropathy. Avoiding diuresis are also great. I use those a lot because liquid intake is not tracked by a lot of people. And if they don't know what they're drinking and they're drinking a pot of coffee a day, there's your urgency. And I catch that a lot. It seems so common sense, but a simple voiding diary, just tell them 2 days worth. And sometimes you can catch that stuff too.
Mhm. Key things for me is absolutely avoiding diary, especially if your goal is improving urinary urgency and frequency. I want to see, is this someone who has polydipsia? Are you drinking 2 liters a day? There's not a lot that we could do regarding that. If that is your fluid consumption, and that can be a lot, just educating the patient. Absolutely getting a post-void residual. My cutoff is really determined based on what the patient voids. If someone voids out 3 or 50 mLs with a strong urge and they leave behind 200, I'm leaning into that. So I appreciate that insight. And also for me, a urine analysis to see if they have any microscopic hematuria, especially if they're having some irritative voiding symptoms, that would pose me into looking a little bit further at their bladder. Dr. Nitty, did you have any additional insights into additional things that you add to your evaluation?
Well, I would say I think you guys have hit it on the evaluation. I think with respect to a PVR cutoff, that is very patient and situational dependent. So I'll give you an example of a time where I might try an OAB medication, a beta 3 agonist, in a patient with a significantly elevated residual, let's say over 200. And that would be the patient with overactive bladder symptoms. They've been treated medically for BPH, so they're on an alpha blocker plus minus whatever else, whatever other BPH medication they're on. They're uncomfortable with their overactive bladder symptoms, and they are not interested in pursuing surgical or minimally invasive therapy for their benign prostatic obstruction. So if I have that patient and he has a post-void residual of 225 or 250, and he's being driven crazy by his urgency incontinence, I will, in consultation with the patient and with careful monitoring, offer that patient an overactive bladder medication, see him back a little bit sooner rather than later, and see if there is an effect on the post-void residual, and of course, most importantly, if there's an effect on overactive bladder symptoms. So I think if you do it carefully and thoughtfully in conjunction with the patient, there are times when those cutoffs may change. Now, that's a little bit different from saying, well, what's your cutoff in a patient who you're going to treat initially, where you might say, well, if that residual is a little higher, I'm going to start with an alpha blocker and then maybe progress to adding an overactive bladder medication after that. But it really depends on the patient's goals and what other treatments beyond our medications that they would be interested in pursuing.
Absolutely. In terms of additional testing that can be utilized, either of you can answer this. In what scenarios do you order a cysto or urodynamic study? And how often do those results actually change your next step? Adam, if you want to start.
Yeah, sure. I'll resort to cystoscopy and urodynamics if a patient's refractory to the care I've given. So, they're on BPH meds, or I've tried OAB meds and they're not really getting the results that I need. And I think cystoscopy is very helpful. I mean, you can look at bladder wall trabeculation, see that they've got high bladder pressure. Urodynamics can also reveal that. And I think it's very helpful in that regard. But and I think it's even in the guidelines, it's not a first step. Cystoscopy, if you're treating appropriately, you shouldn't need cystoscopy for the first step, unless there's something glaringly wrong with the symptoms and they're not responding to therapy.
And I would agree with Adam, and I would say that if I'm going to do urodynamics or a cystoscopy, I should have in my mind how the results are going to influence treatment. So let's say we have a patient with, we think BPH, they have some OAB symptoms that are not well controlled. And I am trying to decide, is my next step minimally invasive OAB therapy, or do I have to be more diligent in pursuing therapy for benign prostatic obstruction in a situation where that answer is not obvious? Patient has a borderline uroflow, has a borderline post-void residual. In those cases, advanced testing is going to help me the most in making a decision, assuming the patient doesn't have some unusual neurological disease associated with their symptoms, et cetera. So I think it's important that those tests are important, but they're most important when the results are really going to make a difference.
Absolutely. I tend to use cysto or urodynamic study and things that may be a little bit more complex, whether that person has had radiation therapy, a previous outlet procedure, or if we're considering doing an outlet procedure, definitely getting a cysto. But often if we're managing conservatively first or using pharmacologic management, I will not get a cysto or urodynamic study.
Yeah, I mean, we've done cystoscopies on patients with refractory symptoms, thinking, what are we going to find? Just BPH, and you find a bladder tumor, right near the prostatic urethra, and that's causing some obstruction and sometimes irritative symptoms. You never know. So if something's not matching up, it's worth at least doing a scope.
There was some things in the chat about prostate size and obstruction, and Dr. Staskin very nicely pointed out that benign BPH is not BPO. So hyperplasia isn't necessarily obstruction. That said, you can have obstruction with a very small prostate. Remember, the prostate is glandular and there can be a size component, but it's also muscular and there can be a muscular component. And there's no better demonstration of that than primary bladder neck obstruction in a 25-year-old male in retention, which we do see. So remember, it's not always about the size of the prostate. A small prostate can cause big problems, and a big prostate can cause no problems.
Yeah, that's a great point, Dr. Nitty. I do this. I have the same conversation with my patients on a daily basis, and patients picture the urethra as it's drawn on every photo or every book that we have that we show them. It's not a tube that just goes from the bladder through the prostate. It's lobular. I mean, there's nooks and crannies, and there can be obstruction in those nooks and crannies, and the patients don't understand that until you illustrate.
And, we also have a tendency in the United States to use the term BPH to mean the symptoms that are commonly associated with BPH. And I know our European colleagues, it drives them crazy when we use a histologic term to describe symptoms. But when we use the term BPH, we commonly use it to describe the symptoms associated with BPH and not the histologic diagnosis. So that's also an important distinction. If you have colleagues that are from Europe, they will tend to not use that term.
I do have a question regarding clinical evaluation. So if the patient does have mixed symptoms and their goal is, well, to treat my lower urinary tract symptoms or just to treat my urinary symptoms, I'm unhappy, and they can't really distinguish if it's my stream versus if it's urge for them. Like, what top clinical cues do you use that can help you distinguish with your patient whether we need to focus more on storage versus voiding related symptoms?
I think,
Okay. Go ahead, Dr.
you
Nitty.
first, Adam, please.
Storage-related cues tend to focus around urinary urgency and frequency, but there's so much overlap. It's sometimes difficult to tell. Urge incontinence and urgency, like severe keyhole urgency, that leads me more in an OAB direction than BPH, especially if they don't have a high PVR and they're not having any overflow incontinence. But again, sometimes it's the art of medicine versus the science of medicine when you're evaluating some of these patients.
Right.
Yeah, and I stick with my question, what do we need to make better? And usually they'll come around to it and they'll say, I pee too much, or, I'm wetting myself. It's the leakage, or it takes me so long to urinate. Um, you just got to keep at it.
Yeah, sometimes I'll look at the or the pelvic ultrasound, and if I see large bladder diverticula, they've got high bladder pressure. They've probably got more obstructive issues than originally OAB. So I would focus on that as well as the OAB at that time.
Although, Adam, you could get a little bit tricked with that because if somebody has a lot of detrusor overactivity, they are going to have a voluntary obstruction. They're going to tighten their
Their
sphincter to
sphincter, yeah.
let, and so that's the woman with the bladder that looks like the man with benign prostatic
Right,
obstruction.
you're right.
So
And
always
that's
be a little bit aware, but I would say in general, you're absolutely correct, but sometimes you can get fooled with that.
true. And that's where UDS really comes in handy.
Correct.
I will say at some components, maybe not as utilized at some institutes. Sometimes we're using Eurocuff as more of a non-invasive measure, especially if it's hard to get into UDS sometimes.
We're using it. It's helpful.
Mhm. So these are some fantastic points. Once we know whether the symptoms are voiding or storage dominant, the next step is building a management pathway that's individualized and practical. We often begin with conservative measures. From there, we can escalate to pharmacologic or advanced interventions based on symptom dominance and patient goals. However, this does not have to be a stepwise approach. So for our next segment, when we're talking about some different management options, starting with you, Dr. Nettie, what behavioral strategies do you start with typically?
Well, I mean, I try and focus behavioral strategies based on the symptoms that we're trying to modify. So, the most common behavioral strategy would be fluid management, and this is often easily picked. Sometimes it's picked up in the history, but certainly a bladder diary is going to help you determine fluid management. And sometimes it can be tricky because sometimes people will eat foods that are very high in water. So it's not just fluid intake, but certainly fluid management, avoidance of, if the problem is urgency incontinence, maybe a little bit more attention to timed voiding and staying out of situations that can cause problems. Um, if it's a nocturia issue, certainly fluid at nighttime. And I would say that pelvic floor exercises are to some degree a behavioral strategy, and they can be helpful in patients with overactive bladder symptoms.
Mhm. Typically with when we start talking about different foods and fluids, I'll have a list with me, and I'll name the list of them and I say, you never have to stop all of these, but just be mindful of things that may be more triggering to your bladder. So I appreciate that point. And I know nocturia can be hard, and I like to clearly differentiate that with my patients of, are we talking about overactive bladder? This has happened during the day or night, or are we talking about predominant nighttime symptoms? Because sometimes that's not an overactive bladder, right? So those are great points. Now, the pelvic floor aspect, absolutely. Adam, what has been your experience in incorporating pelvic floor physical therapy for male with OAB symptoms?
So I do use this therapy for men. It's a hard sell generally at the start, but I tell them everything that they're going to experience before they go. And I've
Mhm.
had success, with teaching a man to do a proper Kegel is almost impossible. And sending him to a pelvic floor therapist who's experienced and can use a little biofeedback maybe to teach them which muscles they really have to start working on, that can be life-changing for some of these patients. And a lot of these patients with OAB have an overlap with chronic prostatitis, non-bacterial prostatitis symptoms. So that OAB can treat, or the pelvic floor therapy can treat both. That spastic pelvic floor, calming it down can really teach them how to ignore that urgency, especially when they've got incontinence episodes.
Whenever I review like absolutely. Whenever I review some OAB options, I typically draw out everything, or I'll have a list with me. Not so much as a stepwise approach, but they're all on the board, and pelvic floor physical therapy is on there. I try to educate, but do either of you have any instructions as far as any in clinic, or are there any specific nurse visits that you use for any like biofeedback or like urge reduction strategies? Say if they're not able to make it into pelvic floor physical therapy, or they live in a location where they cannot pursue pelvic floor physical therapy.
We do. We have a couple of different handouts. The ones that I use most commonly are it's a handout that I made. It's in my language that tries to describe a pelvic floor exercise, how to do it, how often to do it. That's gone pretty well. We do have biofeedback available in our clinic. It's limited access. We don't have somebody dedicated to doing that 5 days a week, all day long. So it's limited access. And the biggest issue we have with pelvic floor physical therapy is access, because we just don't have enough pelvic floor physical therapists in Los Angeles to meet the needs of our patients because obviously we use it for things other than just lower urinary tract symptoms. But we try and arm the patients with instructions, and there are some reasonable online places where you can go that do a pretty good job of describing pelvic floor muscle exercises.
Absolutely. There's a question in the chat regarding if someone has BPH and obstructive, BPH and OAB symptoms, is it okay for them to pursue pelvic floor physical therapy? The answer is absolutely. But I tell my patients it's more than just a Kegel exercise. It can be diaphragmatic breathing with this when the urge comes about of when to do that type of exercise. So a lot more goes into it than just telling them to squeeze their pelvic floor.
Right, and teaching patients that just because they're doing Pilates doesn't mean they're catching all those pelvic floor muscles in their workouts.
That's true. Dr. Nettie, do you sequence BPH medications before OAB medications, or can they be initiated concurrently?
I do everything from let's say the patient has both overactive bladder and what I think is benign prostatic obstruction. Depending on the patient and the uroflow post-void residual, I might start with an overactive bladder medication, I might start with a BPH medication, or I might start with both.
Absolutely. I think a lot can go into what we're initiating based on the patient's competing comorbidities, their age, and some of their risk factors too. There's a question in the chat regarding the use of a low dose daily tadalafil, and I know our BPH guidelines currently do highlight the use of tadalafil. Is that something that any of you are using in your practice?
Sure, every day. And there's a lot about tadalafil we don't know. I mean, it's being studied for anti-inflammatory effect and all sorts of other things. And I've seen great success using it initially for bladder outlet obstruction symptoms, but it also seems to help once they've relaxed that obstruction. Sometimes their urgency gets better. So I use it all the time.
Yeah, I have no problem in using it in a man with presumed benign prostatic obstruction and symptoms related to that.
Mhm. Sometimes in my educational points, I'll talk about how you can hit three birds with one stone. Sometimes we're talking about improving obstructive symptoms, irritative symptoms, and possibly improving their erections, right? With that low dosage daily. Adam, so once we initiate some of these measures, what's your reevaluation interval to measure success and adjust treatment?
Well, when I do change a therapy like this, I usually bring a patient back within a month, usually at 4 weeks.
Okay.
I often tell them that medications can take 2 to 4 weeks to even start really affecting them. They're not immediate. Maybe Flomax or Tamsulosin might be more immediate, but some of these OAB medications take time. So I tell them to be patient and bring them back in a month and reevaluate. And then I'll spread them out from there. If they're improving or if I'm changing therapy, I'll keep them on a month. PTNS, when I'm using peripheral tibial nerve stimulation, sometimes it works in 3 weeks, sometimes it takes 11. So I tell them whatever I'm going to use, it takes time and to be patient. And really giving them expectations ahead of time can really save you a lot of frustration with the patient.
Absolutely. Definitely dependent on what we're moving forward with. And that for the follow-up, I'll incorporate a patient portal message back to me in that 4 to 8 week time frame, or we can do a televisit, which is something we're starting to utilize more in our practice and makes it more convenient for the patient, especially if we're not doing something in person, unless
Sure.
that's what they prefer. Now, question, how does age or cognitive status alter your treatment pathway? Dr. Nettie, would you answer first?
Well, I'm going to give you a little bit of a surprise answer, and I would say not all that much. And the reason I say that is because obviously, when you have an older or frailer patient who comes in who already has cognitive dysfunction, the last thing you want to do is give them something that might worsen that cognitive dysfunction. For example, an antimuscarinic agent. However, when you think of a younger patient who may be on therapy for many years, you also don't really want to expose them to something that the literature would suggest with more anticholinergic burden, the risk of cognitive dysfunction increases. So I prefer to stay away from medicines that can cause cognitive dysfunction in all patients, but it is certainly obvious when you see somebody who may have cognitive dysfunction to start, especially if they know it. If you tell them there's a medicine that may aggravate that, they don't want to even, the conversation ends there because they're done. So I mean, yes, we're careful in the elderly who already may have cognitive dysfunction or may be heading in that direction. But I think we should also be careful in younger patients who may be on these medications for many years, and that antimuscarinic or anticholinergic burden will increase with time.
Unfortunately, giving the insurance companies this answer is not always adequate.
Correct.
So, sometimes you have to stepwise fashion some of these medications, and there are some antimuscarinics that are maybe a little less cognitively dangerous than others. And I mean, depends which study you read, but sometimes you have to get away with maybe prescribing a little bit at a time and then trying to get the beta-3 agonist when you can, or go
Right.
other therapies.
Yeah, I mean, and in all fairness, there are patients who do preferentially respond to an anticholinergic agent, and there are patients who optimally respond to combination therapy of both a beta-3 agonist and an anticholinergic. But
Right.
and I think in those cases, you explain the risk, the patient sees the benefit, and you move forward. But initially, if it's my choice, I always prefer to start with a beta-3 agonist if at all possible.
Absolutely. And I think that educational piece of explaining each of those, because you could have a patient that's been on an antimuscarinic for a decade and, it's gave them some benefit. They just want you to increase it. But our part of explaining, hey, these are the side effects of this medication that can definitely turn the lever around, and they may want to change medication by knowing some of the side effects that go along with it, especially if they've been experiencing them but did not know. So since we're talking about medications, so we've had some wonderful pearls so far, and that brings us to the next step of our segment today. So for many years, starting a man on an OAB medication was taboo. The 2024 guidelines supports the use of antimuscarinics and beta-3 agonist therapy alone or in combination with BPH medication. For men with persistent storage symptoms, understanding side effect profiles, expected timelines, and follow-up is key. Dr. Nettie, what are cases where you would trial an OAB medication before addressing voiding symptoms?
Certainly in cases where the overactive bladder symptoms are the overwhelming problem, and in a patient who empties his bladder reasonably well, I'm probably almost always going to start with an overactive bladder medication in that case. Again, assuming a reasonable uroflow. It doesn't have to be normal, but not a Q max of 2 milliliters per second. Not to say that I wouldn't use it in that case, but I may not start with it in that case. But I think when the OAB symptoms are most prevalent and the obstruction is not concerning or dangerous, I would start with an overactive bladder medicine first.
If the patient that you're currently seeing is on a antimuscarinic and they're still having those irritated voiding symptoms very predominant in their life, maybe had some benefit with it, would you consider combination therapy, or would you directly switch them to a beta-3 agonist to trial first?
That's a very individual decision based on so many factors. You have a few options. You have a switch out, you have an addition, or you have adding an alpha blocker. And I would say depending on the situation, I would do all of those things. Again, depending on the situation. Now, when I typically, in general, but not always, if I have a patient who, let's say, is on an antimuscarinic, and I want to add more overactive bladder, or I want to do better for their overactive bladder symptoms, what I will typically do is add a beta-3 agonist, and then if they're very much better, then I'll try and remove the antimuscarinic. So not do two things at once, but do one thing at a time. Again, ideally, I'd like to get the patient off antimuscarinics if they don't need it, but if it's really helping them and they understand the risks, I'm fine to have them stay on it.
Yeah, I do the same thing when I have a patient who comes in already on an antimuscarinic. They've been on it for years, but they're just starting to get breakthrough symptoms. Then after evaluation, we can sometimes add a beta-3, and that does the trick. And then certainly pulling off when we can, so they're not, a lot of these patients are polypharmacy anyway, so we're trying to minimize that when we can.
Before we initiate some of these OAB medications, meaning beta-3 agonists or antimuscarinics, Adam, what safety counseling do you emphasize for men starting on one of these medications, particularly around the risk of urinary retention?
I mean, so I mentioned that with every patient, and I don't try to scare them. I just tell them what the symptoms are to watch for, slow urinary strain, pushing, straining. And I'll tell them that, look, we're gonna evaluate you. I'm gonna see you in a month anyway, and so we'll catch it if it's really getting bad. But I tell them the symptoms to look for, so we know that they're aware. It can even happen. I mean, it's on the literature for beta-3 agonists, although I've very rarely seen it. But you still have to talk about it.
So,
Yeah, I mean, I would agree with that. With both, it's low. If you look at the studies that have looked at this, you would say it's probably insignificant compared to placebo. But it is, I do always mention it as something to look out for, but I suppose I'd probably mention it also in a patient who's on watchful waiting.
Yeah.
right.
I find that, we have the luxury of having imaging in our offices. We have at the very least, a bladder scanner. And in primary care, when they're prescribing these in the past, it was such taboo for an OAB medication because they don't have a bladder scanner and they're not checking for that residual in their bladder. So I think we have a little more luxury in our practices to say we've evaluated and this is going to be safe.
So what about your just generalized education for beta-3 agonists and antimuscarinics? Is that something where when you're talking about it with your patients, you're explaining both side effects of both and letting them choose which one, or how do you go about that?
For me, it's which insurance plan do they have? Sadly. But also, if they've got uncontrolled hypertension, I may not put them on mirabegron. If they already have a lot of nasopharyngitis issues, I may try mirabegron over the other, virabegron. So I try to be open with those, but again, the side effects tend to be so low on these medications. I don't see a lot of adverse reactions on these, and sometimes they'll have a tick in blood pressure, but not uncontrolled.
Yeah, I mean, I think the biggest challenge in practice is when you start somebody on a beta-3 agonist, or give them samples, it's successful. They tried to get it from their insurance, it's not covered, and you get a call and is there an alternative? And it's not as easy as to just say, okay, we'll give you the antimuscarinic that's covered without you. I think in today's day and age, you must have the discussion with them of the potential side effects and the association, whether it's causative or not, of cognitive decline with an antimuscarinic. So it's almost like another visit or a telemedicine visit rather than changing from one beta-3 agonist to another, where that's, oh, your insurance covers this, okay. So it's, they have to be educated on that topic. And the question is, do you do it in the first visit or do you do it when it becomes obvious that you want to prescribe an antimuscarinic because either a beta-3 agonist didn't work well in the patient, you want to add on or switch, or if the patient does not have access to a beta-3 agonist?
Typically in my practice, I'm talking about it all at the first visit. I want all the questions addressed at the beginning. And when it does come to a time of initiating an overactive bladder medication, sometimes I'm able to communicate with the pharmacist. I'm able to send mirabegron and vibregron to the pharmacy with a special note for the pharmacist that this patient does not need both medications, but will contact to assess financial cost and kind of go from there. So the patient isn't stuck at the pharmacy with the medication that they're not able to afford and move forward with in their care to create those delays.
And when you do have the opportunity to use incentive programs, et cetera, to make it easier for patients, there are programs out there and that can certainly be helpful.
And I think from the backtracking a little bit to the safety counseling beforehand, Dr. Nadine, when you had mentioned earlier where the conversation just stops after you talk about the cognitive decline, absolutely that can happen. But I'm glad that I can say it out loud so the patient is aware. But definitely that scoots along the conversation to what else is out there, because I will make sure that hopefully that's available to me or we can do something else. Typically that's kind of what the patient is telling me. So I appreciate the safety counseling aspect.
Yeah, I mean, you don't, and I don't sit there and tell the patient, well, if you take this, you're going to have dementia in 3 years, but you just have to, you have to make them aware. Although, I have patients now that come in. I had a patient today and, we were talking about prescribing a medication and they knew, not the specific medication, but they knew that some of the medications to treat overactive bladder are associated with dementia. They knew. So the word is starting to get out there.
Yeah. And I appreciate those questions as they come about. And one last backtrack for the question regarding urinary retention with it. Are y'all considering, or do y'all add anything into your follow-up of any concern with urinary retention? Typically in my practice, it's not high on my concern list. I'm not following up with a portal message or making them have to do like a residual 4 to 8 weeks later to ensure they're emptying, unless this is someone who does have an elevated post-wood residual and I'm very concerned. But most of the time, no.
I agree.
Yeah, I agree too. And that's often where I'm using the IPSS scores, because if you see those obstructive symptoms going up, then I would look into it deeper. I'm not always doing an ultrasound on every patient, especially if they didn't start with any retention. I look for symptoms too.
So Adam, what are some common pitfalls you see in OAB pharmacotherapy management that we want to make sure our audience avoids?
I mean, I think number one, and I find this in my practice a lot, update the medication list first. I always ask before I prescribe what are your medications, and I'll look at what they're on, make sure I'm not missing something. Um, don't miss a glaucoma diagnosis, narrow angle glaucoma for an antimuscarinic. Don't
Mhm.
miss Parkinson's, or other neurologic conditions that could be contributing to their symptoms, and maybe you can't prescribe certain medications. So I'm always doing that with the medication checks and diagnosis check. I'll also check if they currently have xerostomia, dry mouth, or they already have constipation, or current dementia or memory issues. I'm always asking about those things too before I prescribe, just so I'm not adding to it.
Dr. Nettie, any pearls moving forward as far as common pitfalls to avoid?
I mean, I would certainly agree. I would certainly agree with Adam. You make sure the patient doesn't have obvious contraindications to something that you're going to prescribe, and just, I mean, you can simply mention the side effects and make sure that that is something that if the patient were to get it, it's not going to be a catastrophe. And also tell them, if you do take a medication that has a side effect and you get that side effect, you can stop the medication.
Are there any certain parameters that you are using for to define treatment success, whether it's like having them repeat avoiding diarrhea or just that sending that message in like, hey, 4 weeks later, things are better?
I mean, in clinical practice, I have found the most useful thing is, how are your symptoms? Are you happy with the medication? Do you think you need anything else? I'll ask those three questions. Um, it's less about in day-to-day clinical practice, it's less about using those more PROs, patient-reported outcomes, and more objective things. However, it doesn't always work. And as Adam mentioned before, patients forget where they started sometimes, and they forget how much better they actually are. So sometimes those more objective parameters are important to help a patient realize where they've come from. And there are some times where the goals may be unrealistic, or we just can't quite get there. And we have to remind the patient, look at where you were. You forgot where you were. And I think that's helpful in reinforcing it. But day to day, it's usually, and if they're not happy with the therapy, why are you not happy? What needs to be made better? And I think in day-to-day clinical practice, for me, those are the most important things. That doesn't hold up in a clinical trial, but day-to-day practice isn't the clinical trial.
Absolutely. Those are the things I want to hear to make sure you're on the right route. So this was an excellent discussion. Now let's turn to what happens when medications are not as helpful for the patients, and we're considering some advanced strategies. It is interesting to note that even after treating obstructive symptoms, about 20 to 30% of men continue to experience overactive bladder symptoms. Advanced evidence-based therapy options for OAB include intravesical chemotherapy, tibial nerve stimulation, and sacral neuromodulation therapy. Selecting the right therapy requires balancing symptom burden, comorbidities, and patient motivation. Adam, how do you identify candidates with mixed symptoms for an outlet surgery?
That's a great question. I typically it's going to have to do with high residuals. The patient's just not responding to medication for BPH, and they have high residuals. Large median lobes are often, they always catch my attention as well. I'm clear before surgery in these patients, though. I mean, if you move forward with a patient who's got high residuals and symptomatic and they're not responding to medications, I tell them, look, we may clear your obstructive uropathy, but you still may have an overactive bladder. And I try to be clear with those patients. A lot of times, majority, they get better. But there's that cohort of patients that you do everything for them, but their bladder's already got dysfunction. And like Dr. Nady said at the beginning of this talk, they're two different processes and they could be completely independent. So you have to really let them know, I'm going to do what I can to clear this obstruction, but you still may need some medication for your overactive bladder or whatever therapy that we've discussed. So my workup is typically, the PVR. We can do urodynamics as well. Cystoscopy is actually very helpful to tell the degree of obstruction, and then moving on to a surgical solution.
Dr. Nedy and Nedy.
I mean, it's sort of the same. So most patients prefer to avoid surgery if possible. Now, that's not every patient. So surgery is on the table for some patients at an earlier time. But it's usually, surgery is usually for the patient. Again, we're talking mixed symptoms now, not the straight retention or obstructive symptom patient, but patients with mixed symptoms. The patient is not happy with their treatment so far. Their symptoms are not well controlled, and either if I'm highly suspicious of obstruction, the conversation comes up. If I'm not sure, that's where urodynamics comes into play. And like what Adam said, as in those patients who have not responded to medical therapy and behavioral therapy, et cetera, as far as the overactive bladder symptoms are concerned, I tell them, in roughly 2/3 of patients, those overactive bladder symptoms will improve when we relieve obstruction, but that means 1/3 they won't. But you could respond to overactive bladder medications better when obstruction is relieved, or it might open up other treatment options for us, such as onabotulinum toxin A. Now, one thing we don't know is how well does neuromodulation work on overactive bladder symptoms in patients who clearly have obstruction? That question that's up for grabs, and people will give you different opinions on that, and certainly it probably does work in some patients. Botulinum toxin, you always worry in the obstructed patient about putting them in retention. And for some, that may be a good thing, but for most, that's not going to be a good thing. But when you relieve obstruction, if those overactive bladder symptoms don't go away, and I tell them very clear, 1/3 is a high number. So patients shouldn't be totally disappointed if overactive bladder symptoms don't go away. And oh, by the way, they may get worse, particularly urgency incontinence, because when you relieve obstruction, there's less outlet resistance. So what used to be urgency can turn into urgency incontinence if the overactivity doesn't go away with the outlet procedure. And I think you got to tell them that too.
One common educational point I have is, one, I never tell someone they have to have an outlet procedure, but I like to emphasize the aspect of like bladder remodeling, and this can also be preventative for worsening their irritative voiding symptoms, especially if I have someone with mixed symptoms, whatever predominance, and they definitely have some obstructive symptoms and they're 50 years old and down the road, yeah, this could be getting worse. So that educational point sometimes leans those towards wanting to do something more preventative, and that may be an outlet procedure versus considering some of our medications meant for more obstructive symptoms. So at least things don't get worse.
Some of these guys, they have small prostates. You're talking about a guy in his 50s, some guys in their 40s with both symptoms, OAB and BPH. Sometimes a minimally invasive procedure can, relieve the obstruction and sometimes help the OAB symptoms, but oftentimes they're still going to be on an OAB med if it's too late, if they've already had that bladder remodeling.
In either of your practices, Is there any incorporation of an outlet procedure with Botox at the same time if someone has clear refractory OAB symptoms and significant obstructive symptoms that medications are not assisting with?
So I mean, I don't think it's wrong to do that, but I tend to do it in a staged manner with the idea that, hey, if I'm telling them 2/3 of the time the overactive bladder can get better, then I'll usually do that staged, but I can certainly see the reasoning, and there's literature to support doing the two at the same time.
Same answer. I haven't done both at the same time in our practice, but prefer to see if we take care of one issue, is the other issue going to calm down, or do we have to take care of the second issue on a separate visit?
So for predominant OAB symptoms and those who have a prostate, Adam, how do you decide between if someone has tried medications, there isn't there for them, or they don't want to pursue medications, they want to pursue an advanced strategy? How do you decide between chemodenervation, tibial nerve stimulation, or sacral neuromodulation?
For me, it's really just getting to know the patient and their expectations. For chemodenervation, any patient with a significant residual, I'm probably not going to go that route. But I mention all three therapies when I'm discussing what the future holds as far as other therapies besides medication. We talk about the pros and cons of all. Some of them, have lower back issues. They need a lot of MRIs. So maybe an InterStim's not the right, although now InterStims are a little safer for MRI. For some coming into the office, I always look at their address when I'm talking about peripheral tibial nerve stimulation. If they live 40 miles away, they're not coming in every week for PTNS. So I will switch gears for those patients, especially for something like neuromodulation or botulinum toxins. So it just depends on where the patient is, how severe their issue is, and what they're willing to do to overcome it. The InterStim procedure trial is very simple and virtually non-invasive. It's one lead, and when you pull it out, there's nothing left, and it's not a surgery. That's an easy sell for some patient who lives 50, 60 miles away and just is really frustrated at their symptoms. And some patients don't want to get Botox or botulinum toxin every 6 months. They want it one and done. So it's just talking to your patient, knowing what their expectations are, and that kind of leads me in the direction of which therapy I'm going to push for them.
Yeah, and I would agree. I think it's ultimately a patient decision. There are instances where I may be biased towards one therapy over another. I will tell patients there is more data on neuromodulation for treating OAB dry than there is on botulinum toxin for treating OAB dry, because the large studies for botulinum toxin were done, all those patients had incontinence. So it may be that neuromodulation preferentially treats the OAB dry patient, although there's never been a head-to-head study that has proven that. So if somebody prefers Botox and are in that situation, that's certainly okay with me. I give them the information that I have. If I think somebody's at high risk for needing to catheterize after Botox, I will tell them that. The patient with detrusor underactivity, the combination of overactivity and underactivity, always a challenge to treat, or the patient with a degree of obstruction who elects not to treat that with an outlet procedure. Maybe not an overwhelming obstruction, but maybe a component of obstruction that they prefer not to do any sort of prostate surgery. Just let them know that I think the risk of needing to catheterize is higher with Botox, although honestly, I don't know that that's ever been absolutely studied.
The conversation definitely can change when we review all of the risk of those. With the tibial nerve stimulation, definitely the driving aspect. And with the Botox, yes, when I mentioned the risk of urinary retention and having to potentially use a catheter, eyes grow. Even
Always.
yes, even with talking about the risk. So there's a question of do you ever use PTNS with those with cardiac implants?
Yes, I do. I always get the cardiologist clearance on it. Most of them say no problem. I had one give a patient the magnetic donut that turns off his defibrillator during the procedure. He was really worried about electrical impulses. But as long as you get clearance from the cardiologist, I have no problem doing it.
I agree. It's something, there's no contraindication with the cardiac implant with signal modulation. I hate that it's for the peripheral tibial nerve stimulation, but yes, getting clearance with cardiology, making sure that we move forward safely and appropriately. That's something that I do too. So I would like for each of you to answer this question. Adam, starting with you, what's one insight you wish every provider knew before managing someone with a prostate that has OAB?
Only one? I guess we're limited on time.
You could do
Um,
1.5.
all right. I mean, just that OAB symptoms are progressive. Just know that OAB is a progressive disease, and you're by the time they get to you, they've probably had this for some time. So just keep in mind what their history is, and when you're making their therapy plan, to talk about the non-pharmacologic therapies along with pharmacologic. So you have a lot of options with this patient. Most of my visits are deemed, I can't bill for it, but it's uropsychology. There's a lot of anxiety and there's a this is a chronic disease. There's a lot of depression, and you're really trying to help patients overcome this daily trigger of theirs that they've lived with. So keeping that in mind and giving them hope with all these different therapies, I think is key.
Yeah, and my point would be, the patient has a bladder and a prostate, and don't forget that. And one of I always say one of the nice things about being in urology, and I have partners that are urogynecologists, and they see just women. But I always, after the years that I've been doing this, I always say that I've learned a lot about men from women, and I've learned a lot about women from men. And we have tended to make assumptions based on anatomy and gender that while there's certainly some things that are true, there are some things that you may apply principles related to how you typically think of the opposite gender and say, wait a second, if this works in a woman, why might it not work in a man? So you should always think, the bladder is the bladder. And yes, the prostate affects how the bladder works, but it doesn't always affect how the bladder works. It's not always the culprit.
That is a great point. Thank you, panelists.
Thank you.
Thank you very much.
So the consistent theme tonight was OAB in males is common, underrecognized, and treatable. Thank you to our panel for your wisdom and to the audience here for advancing your care through curiosity and collaboration. That concludes our panel discussion today. Thank you for joining this evening.